Hello, everybody. Welcome to the latest edition of Infection Control Matters. Martin's with me today. G'day, Martin.
G'day, Brett. And it's nice to be talking to humans again instead of letting the AI generate like the last one.
That's right. If you haven't heard our podcast from last week, it was an interesting one using AI to generate a podcast. But anyway, we have got real people today and two exciting guests. We have with us, we have Sanne from the University of Melbourne. Welcome.
Thanks, Brett. Hello, Martin.
Hi, Sanne.
And we have Kirsty Buising as well. And Kirsty's from the Royal Melbourne Hospital and also from the University of Melbourne. Welcome, Kirsty.
Hi, Brett, and hi, Martin. Nice to be here.
Nice to see you again.
It is. And today we're going to be talking about a paper that you've recently just had published in Infection, Disease and Health. I think it's still hasn't got an issue number or anything yet. I don't believe. I think it's still online early. And we thought we'd have a chat with you about it. It's called The Analysis of Infection Prevention and Control Documentation in Residential Aged Care, and it's based on a behaviour specification framework. And I think this kind of got our interest because we have a lot of listeners who are particularly interested in residential aged care and infection control. Often those podcasts are ones that get a lot of listens. And so we thought, what a great opportunity to explore this with you both. Maybe I'll start off and just perhaps go back a step and just sort of tell us a little bit about what was the idea behind doing this piece of work? What were you wanting to achieve?
Well, Brett, this is part of a bigger project that Kirsty and some other team members have been working on. And we were specifically interested in how guidelines and policies and procedures are written, because given staff members use them to build their practice on, it can be written in many different ways. And it could be very brief, like, for example, perform hand hygiene, or it could be more elaborate, say, personal carers wash their hands with soap and water before touching a resident in the resident's room. So we were thinking, if documents are based on very brief descriptions, it might be a bit vague and people might be confused about who does what, when and how. And especially in residential aged care, where we've got different staff members, we've got nurses, we've got personal carers, there are lots of things going on, lots of things to keep in mind. We thought how those documents are written surely must matter.
It's a really important point, that documents, how you write documents. Kirsty, you probably have this from the acute setting side too, in terms of that balance between how much do you put in, how much is enough information, and being too prescriptive, I guess. Is that something you find in the acute care sector as well, Kirsty?
Yeah, absolutely. I think we have to be a little bit more reflective about how we approach writing guidelines and implementing guidelines. And I think you can't just assume that you summarise the evidence, present it to somebody in a guideline and tell them to follow it and it's going to happen. Like, it doesn't. We all know that. We hear that over and over and over. And you've got to, I guess, learn to apply some of the implementation science thinking that Sanne's an expert in to really try and critically analyse how you're translating that guideline into a document that people can practically use. So whether it's in primary care or hospital care or residential aged care or anywhere that you're following a policy or procedure, how are you translating that information into something that is, the phrase that we always use is in infection control is make it easy for people to do the right thing. If the right thing is the easiest thing to do, and if we make it really clear, really explicit, and remove all of the complex language or assumptions that are behind things and step people through how to apply that evidence to their context in a meaningful way that matters to them in their workflow, then, it's more likely that would be taken up. So I guess we brought Sanne's expertise in implementation science thinking to this problem of infection control guidelines and why aren't they always being followed, and how could we learn to improve the policies and procedures that we design to try to bring them to the point of care.
Sanne, could I ask you then what the framework is that you use then? If you could just tell us a bit about the framework that you've used, because I've not seen that used in an IPC world before, not in acute care, let alone residential care.
Yes. So it's an ACT framework, and ACT has two A's. So it stands for action, actor, context, time, and target. And the idea behind the framework, it's a behavior specification framework. So it's very much thinking about, if we describe all of those elements, it should be more actionable. It should be clearer for people to act upon it. So if you have an action in there, you have an actor in there, it should be clearer. So that's the idea behind the framework. And we use the framework in two different ways. Firstly, we were looking at the extent to which local policies and procedures were evidence-based. So we did a comparison between local policies and procedures and the national guideline. And secondly, we were interested in how specific or how actionable are all these documents. And we used the framework for both of those angles.
Before we get into this a little bit more, because this is fascinating, just I guess for the wider audience that aren't from Australia, Australia has some national guidelines for both healthcare settings and also for residential aged care. So when you talk about guidelines, national guidelines, that's what you're referring to?
Yes. So I know many people call it clinical practice guidelines, but the idea is that they're evidence-based and they're national. So there is a national acknowledgement that those are the right ones to follow.
I think we're probably in a privileged place, because I don't know that many countries have national infection control guidelines around specifically for residential aged care. What do you think, Martin?
I think you are in a pretty privileged place. I was just wondering about who actually writes the local policy then. Who would be responsible for that? And would that be responsible for some of the discrepancies that you find later on in the document?
Yes, no, that's an interesting one. I think there's quite a bit of variety of who writes those local policies and procedures. And I think it should be written together with the staff who actually to act upon it. I think often it's written by the management or the provider.
Sorry, I can just hear choirs of angels singing in harmony with that comment. I completely agree.
So I think we can definitely consider how we write them and have areas of improvement.
So maybe before we talk about that, do you want to just describe to us about where the study was done and how you actually went about this particular piece of work?
So firstly, we looked at the national guideline. So we looked at all the statements that are in there, and statements are just actions, sentences with verbs. So we really analyzed them on a very detailed level. And then we compared that with all the statements written in local policies and procedures. And we had 10 facilities that engaged in our study. Those 10 covered 8 providers. So we had 8 documents, so 9 in total. So we compared them all based on the content. We did a content analysis, and that was very much looking at similarities. If the statements were similar enough, we concluded that there was alignment. And then secondly, we looked at specificity. So we looked at all the statements individually, and we looked at, is the actor present? Is the action present? Is the target, the time, the context? Is all of that present? And we had eventually a very huge Excel file, but we tried to really dig into it and try to see, is there enough specificity in there? And we actually found that specificity was generally low. The time was very often present, but often we were lacking the actor. So not really sure who should be performing the action. Often the context was missing. Is this happening in the residence room? Is this in the communal area? So those were areas that were really frequently absent. And generally, we also found that when we looked at the content, the overlap of the content between local policies and procedures and the national guideline was generally low. So we would like to see that higher, because it should reflect the evidence base. And we concluded the alignment of the content was generally low.
I mean, you made a good point that the actor is often missing. And one of my pet hates is the phrase infection control is everybody's business, because then it means it's nobody's business. So
yes,
just can I ask you
exactly.
how we can make this a little bit more specific to people? How might we go about that so that it's your job to do this, not it's just part of a general, it should be done?
Yeah, I think it gets down to actually being explicit in the policies and procedures. So, Sanne looked at things in detail, things like whose job is it to make sure that the hand hygiene dispensers are full? That they haven't run out of alcohol-based hand rub. Whose job is that? Be clear and be explicit about who's responsible for procurement, who's responsible for actually checking that it's filled, and then talk about who's responsible for actually using it, and then drilling down into, as Sanne described, when are they using it and where and before interactions with whom? So is it before interactions with other staff? Is it before interactions with patients? Is it before interactions with, family members or anyone else that they're interacting with? It's just not, many of the procedures and policies that were looked at were just not specific enough to really know what they were asking staff to be doing. So I think that's what we're challenged to do now is to think more carefully and break it down. We're not saying, Sanne will also say that we always think it's important to have a balance. You don't want to overdo it here, and you don't want to make it tedious to read, but for the really important stuff, just be clear about what you are actually asking.
Some things might be implied, like the target, that could be the resident, but we think that it should be clear enough to act upon it. But obviously, if it's too straightforward, it doesn't make sense to make documents longer than needed.
And I'm just wondering on a real practical level here, when you mentioned the Excel spreadsheet that you tried to pull that or do that content analysis in, I guess, and comparison in, I can imagine that would have been rather large, was it?
Oh, that was huge. Yeah, that was enormous. Yeah.
There's no software that can do it for us these days. No, not yet, perhaps. Maybe AI one day.
No. Yeah.
So I was going to just ask about, you talked about there was variations and alignment and non-alignment between local policies and guidelines and procedures with national guidelines. Could you give us some examples of anything that was actually really better aligned? Like, did you find some IPC themes that were better than others and others that were really poorly aligned?
Yes. So one statement, for example, that was in the guideline and covered by all 8 residential aged care providers was washing hands with soap and water if hands are visibly soiled. Another one was, it is recommended that routine hand hygiene is performed before touching a resident. So I guess those are quite straightforward, but those are 2 examples that were mentioned by all. We actually found a few statements in local policies and procedures that were in conflict with the guidelines. So if I can give one example. So one policy and procedure document mentioned wear gloves when assisting with toileting, while the national guideline referred to toileting, you should perform hand hygiene, but not wear gloves. So that was something, I guess, if people use gloves, it's not that they're therefore putting the resident at risk of spreading infections, but because we were so tedious, we could really dig into those detailed differences. But what we also found interesting, we had 12 statements that were in local policies and procedures, but not in the national guideline. And many of those refer to things not to do. And maybe that's quite straightforward as a response to non-compliance or things that are happening at the workplace. So if I can give a few examples, gloves must be changed and discarded as soon as gloves are damaged. Alcohol-based hand rub should not be used on gloves. And another one, do not use multiple gloves at the same time on top of each other. So I think these are probably things that managers have observed in their residential aged care facility. And as a response, they've probably included this in their local documents.
So I wonder, just with your implementation science hat on and within the team, what would the implementation scientists say about writing a local policy of the don'ts? Is that something that is got merit, or something that it just adds bulk if the other stuff isn't clear? That's why you need to do it. Like, where does this dynamic sit in the implementation science world?
Yeah, I think it obviously you need to find a good balance that your document doesn't become too long, but if it's a common so-called mistake or something that happens a lot and it should really not be happening, you need to do something. So I think then it's worthwhile to make it very clear to staff, this is something we don't do. And having it written in your document, I think that is helpful. Often those documents are used as an induction when new staff members start in a facility. So it could be a very good way of saying, look, these are things that we don't do. Yes, I think it is worth including in local documents.
Can I take you back to something you said very early on, in that these documents are what people use to build their practice on?
Mm.
Do you actually think that's true? Because in my experience, if the phone was closer than the infection control manual, people would pick up the phone and call me and ask me things.
Yeah.
And actually, I never had a problem with that, because then you can explain why. Whereas a policy is often doesn't tell you why you're doing something. It's just saying this is the procedure. So therefore, people don't really get the why aspect of it. So I'm going to challenge the fact that people use a policy to make sure they do the right thing, because evidence tells us they don't do the right thing.
No, that's a good point, Martin. And we have that written in our paper, that these are just one of the things that I guess people consider, but definitely calling someone with an explanation of why is extremely helpful. And I would definitely advocate for that. And I would wish that each residential aged care facility has people to call upon, but I know in reality that's not always the case. So if they don't have someone to call, they do refer to documents. And then it's important that those documents are evidence-based and as specific enough to act upon it.
I mean, how accessible are the documents, do you think, as in a readability and making sense to people for the average healthcare worker? Because often the way we phrase things can make them almost impenetrable. So I'm just wondering about the accessibility level of the documents we're writing at all levels in healthcare.
Yes, so the ones that I've read, and as you can hear, I'm not a native English speaker, so English is my second language. I find them very understandable. So it's not that they use lots of difficult words or very complex sentences. I think that they're very short sentences. They're clear to read, but I've seen quite a variety of how content is presented. And I think generally if they're tables or boxes or, break up the text in some way, I think that it makes it a bit easier to read. Also have very clear headings. And I've noticed also quite a variety in that. So I think making the content more, making sure that you find what you want to find more easily, I think that will really help to make it more accessible.
I think you bring up a good point, Martin, and I think one thing we probably should be reflecting on is, at least in the residential aged care facility, there's often not a trained infection control professional available, but rather in the Australian context we have, and Brett can sort of talk about this too, but we have IPC leads who are often staff who exist in the aged care facility who've had some foundational training, but they are not necessarily, fully fledged professionals in the IPC space. And so I guess what you're getting at there is sometimes the audience for these policies and procedures is the IPC lead, who might actually have been called by their staff member on the ward asking a question, and they may be reading the policy or procedure before phoning a friend at a bigger facility to perhaps check that if they can't find what they want in the policy or procedure. But you're quite right. It's not the sort of thing where in the cut and thrust of the day-to-day care that everybody's sitting down at a screen and reading a procedure in detail, but they might well be phoning somebody who is. So we do have to think about who is the audience, don't we?
Is there an opportunity to create like a plain, or these are the key points, shorter document for people to actually get at? And I'm thinking, okay, this is going to sound a bit left field. I play golf. The rules of golf are so thick and so complicated and so open to interpretation that they've had to keep building and building and building. So there's always a rule for something, but there's no way you take the rules. It'd be heavier than my bag and my clubs. So what you have is short summary guides, and people understand those. And then if they have to go deeper, they can refer elsewhere. So is there a scope here for producing something a bit more locally focused, which maybe has the do's and don'ts that is based on the policy? And who might write that then? Because if you've only got an IPC lead who's had some foundational work, then people sometimes might turn to an external consultant to help them write their policy, but they're not local. And as you said, Sanne, they need to be local. They're local people who write the policy. So is there some way of, I'm checking about 15 questions into one here, but who can help people take a national guideline and turn it into something we can use locally in this institution?
Yes, absolutely, Martin. I think there's definitely scope for having a kind of summary at the beginning of that document. Many of these documents are 40, 50 pages long. Like that takes just a lot of time to read. So having a summary at the beginning really helps. Many have table of content, which will kind of help you to easily flick to the right section. But I think having a summary would indeed help. So I think there's definitely scope for that. And to come back to your other question about helping people to kind of translate or convert a national guideline into a local document, I think it should be designed together with the people who actually will use it, whether that's an IPC lead or whether that's nurses, personal carers, but it needs to suit the local context, the local residential aged care facility. So there can be somebody helping in that process, but it should be a team effort, I think. It cannot just be developed by the one person who has a management role and is not familiar with what's happening on the ground.
Yeah, some interesting points there. I guess the other thing that crossed my mind, where you talk about the divergence between national guideline and perhaps conflicting statement within a local policy. I guess there are times where that might be justified, but presumably, I guess, what are your thoughts on where that happens? Should that be made clear from an implementation point of view? Like, so if I'm reading this local procedure and I'm thinking, hang on, that's different to the national guideline. Is that part of the AACTT framework? Is that sort of covered in that context, I guess, of understanding why is there a difference? Because that could be a really important reason why there's a difference.
We've not used it to investigate the why, but I think the ACT framework helped us to identify those differences. So a next step could be to go back to the facility and ask, well, what's the reason behind this? Because you're right, Brett, they might have a good reason. But I think it just helps to start a conversation about, well, to what extent is this evidence-based and should we change it? Is this a mistake? Or I think it's a starting point of digging into this.
One of the big things we hear in sort of the residential aged care, sorry, Martin, is around PPE use and challenges associated with that, and evidence-based. It's perhaps a bit woolly in certain areas, and so for a whole range of different PPE. Did you find in that particular area, for example, further disparities, or was there reasonable alignment between national guidelines and what local guidelines were saying?
Alignment was generally low. It was not worse for PPE in comparison to hand hygiene. So on both aspects, we found it was generally low.
It's often a thing that comes up is about PPE. So, sorry, Martin, you were going to ask something before I rudely interrupted you.
Yeah. It's disappeared now. I mean, I wonder also, is there an element of timeliness and being up to date when writing your local policy, or do people write a local policy and they'll think nothing's changed? And if they are an IPC lead who doesn't get a chance to find out there are national changes in the evidence base, then is it just an out-of-date policy that they just change the date on every couple of years to make it look like it's in date? Or is this just is it they just aren't aware that there are changes that need to be updated?
Yeah, I think it's a good point. If documents are not up to date, it becomes an issue. Again, there was some variety. We didn't really explore how frequently people keep these documents up to date. We do have a date on the documents that we access, and some of them mentioned, the previous iteration was this date. So for some documents, we know it was a year ago. Some were a bit more than a year ago, but it is important to make sure they're up to date. So if there's a change in evidence, it should be reflected in those local documents.
Okay, I've got another question for you, and this is going to be giving you something to say to Brett, because Brett is part of groups that write national guidelines. So should your work influence how they write their guideline to help people make them more accessible?
Yes.
Or could they write an implementation guide to go along with their guidelines on how you could actually develop your local guideline based on their national guidelines?
Yes, no, I think that's definitely what our work is suggesting. And I think both. So it could be a national guideline that comes along with an implementation plan. And I've been in the guideline world back in the days when I was working in Belgium. Many guidelines do start to think about implementation and will have an implementation plan attached to it. But I think also it's how we write the guideline itself that should be specific enough. But given that it's a national guideline, it obviously cannot have all the details that local documents can have. But I think having this framework in mind will make sure that the national guideline can be as clear as it could be at that stage.
It's a good point. And it also goes to the wider debate about any evidence-based guideline for IPC, national and Australia or international guidelines, and how the evidence is appraised and how recommendations are formed and the methodologies that's used to write those recommendations, for want of I guess that's many of the outcomes from evidence-based reviews. And, for example, grade methodology comes with so many challenges in the context of IPC research. But when you choose those methodologies, you're often then stuck with the wording that you can and can't use. So I think that gap then is really important, that bridge between what something might be strongly against or recommend something use of, and the weighting behind that, but how does that actually translate to something that someone can write and implement locally? I guess, sorry, Kirsty, were you going to...
Oh, no, I was just going to, it just made me reflect on the humility we have to have as guideline authors as well, that when people are not following the guidelines, it's not necessarily because they're just not keeping up to date or they're not, they're not doing what we want them to do. It may be because there's a problem with our guideline and we're ambiguous or we haven't thought carefully enough about what we've written to, and I guess that's what I'm learning from this work with Sanne is think carefully about what you're writing so that it's really clear to people, and where they're varying is probably where the gold is in terms of learning how to improve your guideline, because there may be a problem with what you've written that you need to dig a little bit deeper on. I suppose that's something I've sort of learned to stop and think about.
Yeah.
Great point, Kirsty. And I was going to ask the what next question in a minute, but kind of what you just said leads to that. Can you use this framework or to help in that initial writing process? So, use the ACT framework to be very intentional about how you write. Is that one of the things you'd hope that this can help demonstrate and be a useful, perhaps, tool when writing future related procedures?
Yes, exactly, Brad. I think it's definitely a tool of, it provides a process of converting national documents into local documents. But also, I think we have so many local documents already. So I think it could also be used to refine what we've got and double check, is it specific enough? Does this help us look for alignment with the evidence? But very much coming back to what Martin said earlier, obviously documents are not always read by everyone. So these documents are only one piece in the behavioral change complex world. So I think documents are important, and that's what this study focused on. But there's so many other ways that influence behavior, and it could be a colleague, it could be a supervisor, a manager. So very much keeping this into perspective as one piece in a complex situation.
Yeah, I was wondering about, going back to a point you made earlier, when some guidelines or local policy might say don't wear more than one pair of gloves at a time and don't alcohol gel your gloves. Is that because the actual national guideline is so woolly that they actually end up having to write that in their local behaviours because they'll see people just maybe not accept what was in the national guideline? Or is it some sort of local fear? I'm not really sure why they would feel the need to do that unless the national guideline wasn't robust enough. Do you think that was the case there? Or is it it's just a local practice that's evolved?
I'm not really sure, but I think that it's perhaps a local practice that has evolved. People do it, and a new colleague comes in and thinks, oh, that person is wearing two gloves on top of each other. Oh yeah, mine is broken. I will do the same. So I think that's often how things happen. And so I can see this very much as a reaction to observing that this was included in the local document. And also if you think about, the national guideline is based on evidence. I'm not aware of any studies and obviously I'm not an expert in IPC, but I'm not aware of studies looking into the use of two gloves on top of each other and what's the effect of that. So I think that's why we probably don't see it in the national guideline.
I guess the question now is, we've covered the sort of what next in part, but in terms of the program of work that you've got planned and the wider program of work that you're involved with and you're involved with too, Kirsty, how do you see this fitting into that now? What's the next steps that you'd like to see from this?
I think sharing learning is a really key part to this, and we know that trying to manage infection control or infection prevention and control in your own facility can be a lonely business sometimes. So a big part of the ongoing work that this team is doing is focusing on communities of practice between these IPC leads and sharing of learning. And that learning can be more discussive and practical and, based in their lived experience more than, which is different to writing it in an evidence-based guideline that gets issued for use nationally. There's a different type of learning going on there, and we've come to appreciate that you've really got to get down into the reality of the day-to-day and share that learning. So I know that Sanne's team are sort of pivoting to focus a little bit more on what makes the community of practice work in an IPC space and how do you structure that to get the most out of it. But I might hand over to Sanne to speak in a little bit more detail about that.
Yes, that's indeed one area of work that we're focusing on in the next few years. But just to come back to this specific study, we are feeding back to the facilities that participated in our study because we've definitely identified areas of improvement, and I've also seen lots of good things. So it's obviously worthwhile mentioning the amount of overlap with the evidence base. So that's worthwhile highlighting. But we will feed back to them on a more summarized level that there's certain things they can do to improve their documents when it comes to reflecting the evidence as well as making it actionable and readable and accessible. So that's, I guess, just our study. But then more broadly, we feel this is important for others to know. So we have conference where we speak at. We have a consumer group that we meet with, an advisory team that we meet with, and we try to think about different ways of spreading this message because we think it's worthwhile spreading. Yes, so that's, I guess, our immediate plan.
Well, thanks very much indeed, Sanne and Kirsty. I've really enjoyed the paper. I really like the approach to make things actionable. Actionable has always been one of my favourite words, to be honest, because if it's not actionable, nobody's ever going to do it. And getting people thinking about the lines of actually specifying exactly what they've got to do, where they've got to do it, and who's got to do it. Sounds simple, but as you've shown in your review of the policies, that it doesn't always happen. And so, and then you end up in a bit of a fog. So I think this is a nice way to help us clarify and focus our attentions going forward. Brett, any last comment from you?
And I also like how it's going to be built. This next step for the community of practice and the local work that this will help hopefully inform and help. And there's so much of this that needs to get done in all range of sectors of IPC, but certainly residential aged care. So I think it's really going to be really valuable, and hopefully people who are listening can go and read this paper in a bit more detail and perhaps even use the approach that you've used and the framework to be able to think about how they're going to go about this.
And getting a local group to write the local policy based on a national guideline, the people who actually got to do it, that's the way forward. Because I never did that, which is why anything I ever tried to implement didn't work. So there we are.
Well, thank you both so much for your time. We really appreciate it and your great work in this area. I'm really excited to hear about the community of practice, and I think we'll have to come back to you at some point in the future when you've got more to say about that and share what you've worked on and developed in that space, because the sort of concept of community of practice is a term that's often thrown out, and I'm glad someone's actually thinking about what's the best way to approach this in a sector like you are. So that's fantastic. So I'm sure we'll get you back on again.
Yeah. Oh, well, thanks very much for inviting us for today. It has been great. Thank you.
Yeah, thank you from me too. It's been lovely to talk about the paper.
Okay, then. Well, thanks very much for joining us, everybody. And we look forward to speaking to you again on the next episode of Infection Control Matters. Hope you're having a good day wherever you are. Bye-bye.